Dr. Vikas Menon, a senior eye surgeon with lots of prolific skill sets. He would be discussing his most difficult case. Over to you, Dr. Vikas.
Hi, good evening, everybody. And thank you, Team ARC and Dr. Chitra, for having me on board. So I was asked to present one of my most difficult cases, although there are many. And what happens is that over time, when we go back and have a relook at many of those cases, we realize, that wasn't so difficult because we are looking at it from a different angle and a different hindsight we have. But when we are going through that case, that time, sometimes, there are few cases which really consume us at that point of time. And so this is one case that I would like to share, which I saw some time back. And basically it was difficult because of the age of the patient presenting, the relative lack of literature or evidence supporting my problem. Published literature was not much that time. Later on, we published a multicentric kind of a study on this kind of a problem also. So I'll begin with, so this was a 5-month-old male baby who presented to me with bulging of the right eye as per the parents, which was gradually increasing for the last 2 months. There was no other positive history. Everything was normal, a normal full-term child, no history of any prematurity or any other problem, except that he gave history of a meningomyelocele repair soon after birth. But apart from that, no other abnormal history. This is how the child looked like when he presented. This was a 5-month-old child again. So on presentation, there was obviously proptosis, and you could not insinuate your finger into under the orbital rim, and there was a firm to hard palpable mass in the inferior-medial and the medial part of orbit. And on pulling the eyelid, there was a lot of congestion of the conjunctiva, and this is how it looked. So the child was following light, visual acuity was probably there, and pupils were normally reacting, fundus was normal, no other abnormality. Systemic examination again conducted by a pediatrician was absolutely normal, no other problem. This was the imaging, and MRI was performed, which showed an ill-defined irregular inferior-medial mass, which was irregular. And as you can see, it's extending almost through the extent of the inferior orbital wall, extending into the medial orbit also. And on axial scans, you can appreciate that the mass is extending quite posteriorly, almost near the probably the apex of the orbit. It was a large mass there. Now, having this in a 5-month-old child, at the same time, the sinuses seem to be underdeveloped, which one would expect at this age, but they seem to be clear relatively. Now, this was a contrast enhanced scan where you see that the mass was enhancing uniformly and diffusely. But this was a very hard mass to touch. So my clinical differentials that came to my mind at that point of time were the two most common tumors that we see in pediatric age group, granulocytic sarcoma and rhabdomyosarcoma. To rule out granulocytic sarcoma, CBC with peripheral smear was done. Peripheral smear was normal. There were no abnormal cells. And to rule out rhabdomyosarcoma, basically, I decided to proceed with an incisional biopsy under GA. So what came out on incisional biopsy kind of surprised me. So this was the stuff that we got, and you can see what you see here in these scans. The low MAC photographs show, H&E slides will show you granulomas. So there are granulomas with necrosis, and these are multinucleate giant cells. And on GMS staining, these are septate hyphae, which was seen on GMS staining. So basically, this was a fungal mass, aspergillosis, as per the histopathology. Culture was not done because I was really not suspecting an infective etiology at this stage. My main suspicion was a tumor, but this came as a surprise. There were no atypical cells, there were no malignant cells. This was the main problem, granulomas with central necrosis and septate hyphae, which were branching at right angles, confirmed to be aspergillus. So at this age, when a child presents with a fungal infection and with no other problem, so the child was sent to a pediatrician for a thorough evaluation to rule out any underlying cause of immunosuppression. So he was very thoroughly evaluated, and there was no obvious cause for any other immunosuppression. His CSF evaluation was also done, because there was a history of meningomyelocele repair, thinking probably that might be the source of fungal infection, but then CSF evaluation was absolutely normal. Blood cultures were done, which were negative. So based on the findings that of biopsy, intravenous voriconazole was started for a week, which was followed by oral voriconazole. After about 2.5 months of oral antifungals and 1 week of IV voriconazole, the child showed drastic improvement. So as you can see in these follow-up scans that the mass has significantly reduced in size. You can see the medial bulk of the mass reducing significantly, and the inferior, on the coronal sections also you can see that the horizontal expanse of the mass has also reduced significantly. This was after 2.5 months of antifungals, but still there was a lot of fungus still there. So now at this point of time, I was faced with few difficult questions, whether to just continue medical therapy and wait for a complete resolution, or should we proceed with the debulking. And there was always this fear that were we losing time, because many a times in small infants, these fungal infections can be life-threatening, and the mortality rate is quite high in infants and neonates who have a fungal infection. They can go into fungal septicemias, and they can go into an intracranial spread of the fungus as well. So there we were, after 2.5 months of therapy, still seeing some amount of viable fungus here. So discussion was carried out with the pediatrician, with the family in detail. And so a decision was taken to go in for a debulking. So second surgery was performed, this time with the aim of maximum debulking under general anesthesia, and a transconjunctival approach was followed to the medial orbit and the inferior-medial orbit. And as much as possible, the mass was cleared up. This time, because we knew it was fungus, that so the sample was sent for culture as well. But
So you have 1 minute remaining.
And on histopathology, again, the second sample also was consistent with the fungal granuloma, consistent with aspergillosis. Now, this was the situation post debulking. You can see the significant part of the mass is gone, and the oral antifungals were continued. This was the child 6 months post follow-up. The oral voriconazole was continued for about 6 months under supervision, close supervision of a pediatrician. I have had the chance of working with a very good pediatrician. So, and this was a imaging taken 6 months post follow-up. What you can see here is a non-enhancing kind of a mass, which looks mostly scarred now, and it wasn't taking any enhancement. And so this was basically the residual scar tissue left behind after resolution of the fungus. Some amount of scar tissue is anticipated. This is what we began with at presentation. So this was the axial scan of these images taken, say, at 6 months follow-up. So you can see that the medial orbit, which was extensively involved to begin with, is almost completely clear now. And these are serial images of the child on subsequent visits, and this was the last picture that I had from him 18 months from the time of presentation. So antifungals were given for about 6 months, and then 1 year with no antifungals, no treatment. There was no recurrence, and the child was doing well and happy and healthy, and the family was also happy. So this was a situation where ultimately things worked out in our favor, but at that point of time, with a situation like this in a 5-month-old child, it was a little difficult for me on a day-to-day basis. So orbital aspergillosis is relatively rare in immunocompetent patients. We all know mostly these are immunosuppressed patients, and there have been 35 cases reported from LVP and 15 from a series in Ames. And mean age is in adults around 35 years of age, and mostly these cases have PNS involvement from where the fungus travels to orbit. But in our case, there was no sinus involvement, and child was perfectly immunocompetent, and we really don't know from where the fungus got in the system. So to conclude, biopsy and microbiological workup are key to diagnosis in such cases, and most of the times histopathology reveals the correct diagnosis. So one must have a low threshold for biopsy in such situations. Always rule out immunosuppression. Antifungals need to be given for a prolonged period of time, and you need to have a close rapport with a physician or a pediatrician in a situation like this. Thank you very much.
Truly challenging case, and many thanks for presenting this kind of challenging case and bringing out all the discussion aspects. I have a question for you. Like in case of ill-defined mass, most of these masses would be ill-defined. So what would be the surgical endpoint
So the
when we
surgical
do
endpoint is
debulking?
usually depends on your suspicion. Like for example, in a case like this where you are suspecting probably a leukemia or a rhabdomyosarcoma, for those cases, mainstay of therapy is chemotherapy and surgery add-on. So if it's a granulocytic sarcoma, the chemotherapy will work. If rhabdomyosarcoma, then debulking as well as chemo will work. So at that point of time, we did not know really what it is, and so initial where you don't know, so you can just do an incisional biopsy and you can at least have a diagnosis with you. And then based on that, you proceed further.
Regarding debulking, what would be the endpoint, sir?
You don't want to damage the vital structure, you don't want to damage the muscles, you don't want to damage optic nerve. So saving those important structures, whatever else you can take out, try to take out.
So any points to add?
I have
Yes,
a
madam.
question for Dr. Vikas.
Yes,
Very
sir.
nicely presented, Vikas, and very meticulously done. At any point of time, did you think there could have been a fungal foreign body? A foreign body, especially a small, tiny wooden piece or something like that, which because you will much later also you went in for a debulking, which you rightly did. That time did you think at any point of time that you should look for a foreign body, because there were some hypoechoic lesions there on the MRI? Did that give you any suspicion?
Ma'am, that was one thought in mind initially, but number one, the parents were very, very clear that the child is always under their observation and at no point of time child had suffered any injury or trauma to that extent. And also the radiological findings were also discussed with our radiologist personally also, who ruled out any foreign body in the
Okay,
orbit. But that
perfect.
was something which is a very important point that
Because
one should rule
NS
out.
Madam and I in 99 had a case like this from Calicut, I think Cochin. And the second surgery also, we couldn't, some kind of a discharging sinus was there. Very similar presentation. But after the second surgery, still it didn't subside. That time on MRI, the foreign body was picked up and very close to the optic nerve and was really a challenge, a very tiny foreign body. So that's the reason why I asked you that.
Yes, that is a very important point, and I should have mentioned probably that is something which one should
But you have
rule
presented
out.
it beautifully with all the differential diagnosis. Thank you.
Thank you.
I just like
Well, yeah, just to answer what Dr. Vidya was asking, in all debulking, such debulking cases, I utilize microscope. And when you are working under microscope, you can definitely identify abnormal tissue with the vis-a-vis normal tissue, and that really helps. So now in all my orbit cases, I utilize microscope to do the dissection, especially in those cases where it is ill-defined. So that really helps.
The
I
only
think that's a
other
very, very valid
suggestion,
point.
the only other suggestion that I would offer is that you stay on the surface of the lesion under direct vision, blunt dissection only, no cutting, proceeding in a vertical direction rather than in a horizontal direction on the surface of the lesion, and always distinguish it from the neighboring structures and avoid any gross tearing or any cutting. So I think that would be the crux of the matter.
And
A
in this
very,
case,
very
like
well
a
presented,
negatively,
Vikas. Very beautiful case. And the only thing that I would say is that when we have it from the nose as well, then many of these are the aspergillus cases are immunocompetent ones, and they do need debulking because the antifungals are fungistatic, don't really work on such bulk. So I think you did a very, very competent job and very good job. And I'm sure the parents will be eternally grateful to you for the result that you gave them.
Thank you, sir.
I just
Thank
want
you.
to add something. Last week what happened, sir? A patient came to us with recurrent chalazion. So he had this chalazion surgery done elsewhere. Then the second time when he came to us and we had done the scoop out and we have sent a curated tissue for biopsy. And now they are saying that they are seeing big colony of aspergillus. And I'm so scared. Just 2 days back, we got the result, and the patient is from distant place. And we had given a nice vertical incision, thinking it to be the chalazion. So now immediately we have called the patient and started ask him to start an antifungal. But this is for the first time I have aspergillus within a Calesian lesion.
Did
So,
you take the contents of the granuloma on a bud, on a ear bud, Johnson's bud?
yes, ma'am.
Because there could be a contamination from the bud.
No, ma'am.
Aspergillus is a very common contaminant.
No, ma'am. We take the tissue directly. We have what I do, I had taken also the capsule and the contents, and directly from the instrument only we keep it, because it's a good amount of tissue we got it. But that point was always there in the mind. Could it be from some other source? But in our hospital, we do culture everything. Like every once a week, all those cultures, everything is being checked. I don't think, because they tried saying from every aspect, like can it be from any other source in the OT? Nothing came out positive.
Sometimes you get these shocks. I had a 2-year-old child with a sac swelling, and when excised, it turned out to be a fungal granuloma involving the sac. So you can have these unusual things.
And so how long do you continue the antifungal in such situation?
Till you get the desired clinical response. I mean, after debulking, you have to continue it very long and indefinitely. We've had patients who after debulking have continued for nearly a year or more.
Okay, sir. Because this patient, it was a Calesian, everything done, flatten lesion, we had sent him back. And now the culture shows that it is aspergillus.
Now, for a small lesion like that, you may not need to continue for very long. For a orbital mass which continues to show in the orbit for a long time, we do continue. But because many of these are very slow growing and the apprehension with regard to intracranial growth, etc., may not always be very true. If you can just observe clinically and maybe do some imaging every 3 months or even longer, then most of the times you would notice that they hardly grow, especially if they are on antifungals.
I think in Dr.
Because
Kasturi's case,
try natamycin. Sorry, go ahead, Mohan.
Kasturi's case, in Dr. Kasturi's case, there's the luxury of the eyelid. I mean, it's far away, it's not deep in the orbit. And if it recurs, you can always do a excision with a margin and possibly clear it off, which is not there in deep orbital lesions.
Vertical cut, and in case it has gone into the blood vessel.
You could also try topical antifungal if he is not willing to come now.
Yes, ma'am. He is from Tripura, Tripura or some other.
You could do.
Okay, ma'am. So I'll advise also the topical eye drops along with the systemic antifungal.
So with that, can we move to the last speaker of today's inspiring webinar?